Sorry for repeating this, but since the part two on the video had no voice starting from here till the end, so I'm just gonna repeat it so you can get the best of it, hopefully. So the last thing I checked on the video was that we talked about the non-insulin dependent, and it's the more common and usually affects overweight and insulin. It has insulin resistance. Now, the third type is not always present. It affects up to 5% of pregnant women, called gestational diabetes, meaning it affects pregnant females. They become diabetic, but once they deliver the baby, it goes away. The other classification for diabetes can be primary, which is type 1, type 2, or secondary due to drug related like corticosteroids, diuretics, beta blockers, endocrine disorders, pheochromocytoma, acromegaly, Cushing syndrome, pancreatic disease, gestational, considered to be from the secondary type. Now, the blood glucose levels can be affected by food, usually highest 1 to 2 hours after meals. Alcohol can raise it, hormones, medications, and so on. Now, to diagnose a patient with the three P's are most important: polyuria, polydipsia, and polyphagia. Okay, so patients will have excessive thirst, excessive urination, and excessive hunger. Now, in these patients, we might have hypoglycemia, which is the most common and the main acute complication of these patients. Usually, you give your anesthesia to the patient, it's fine, everything is going okay. Suddenly, he becomes irritable. Very rapidly, he becomes irritable. He can become going into vasovagal syncope. Then a strong and bounding pulse, sweaty skin, disoriented, he doesn't know where you are, where he is. Then he loses his consciousness, and sometimes convulsions, sometimes death can happen. Now, how to manage it? Well, before that, what are the causes for it? The causes would be mostly either the patient went and did exercise and he doesn't usually do it, or missed excessive insulin, or missed meal. Meaning he either took his meal and took extra insulin today, or did not take his meal and took insulin. These are the common causes for hypoglycemia. Now, if the patient is awake, we give him something sugary, anything that contains sugar. If he's not awake, we give him either IV or IM. We don't give him anything orally. IV dextrose or IM glucagon. Hyperglycemia, it's slower onset. Deepening drowsiness, but doesn't lose his consciousness. Dehydration, polyuria, polydipsia, all these would be present. Hypotension, acidosis, and ketosis. These are only seen in type 1 DM. For hyperglycemia, we give fluids to equalize the sugar present. Okay? And in hypoglycemia, we have either IV, 20% or 50% dextrose, or IM glucagon. Now, diabetes can affect all types of systems. Cardiovascular can cause cardiorespiratory arrest, atherosclerosis, retinal, ocular, retinopathy, oculopathies, or cataract. Renal can cause renal damage and failure, can cause neuropathies. Most of these patients would have ulcers between their toes and they don't know anything about it. They don't feel any pain. And this is very common. Mucormycosis, infections can be present as well. candidosis, mycosis, staphylococcal infections, and so on. Now, how to manage a patient with diabetes mellitus? First, medical consultation. Second, we need to make sure that the patient has taken his medications and took his breakfast, and an early morning appointment. So once we checked all of those, we ask for a new glucose test. We can go for the fasting blood sugar, which is usually when the patient has fasted for at least 6 to 8 hours, or the random blood sugar, or the oral glucose tolerance test, or the hemoglobin A1C. Now, the hemoglobin A1C is very important. It gives us the collective control over diabetes within 3 months. But the more accurate test is the oral glucose tolerance test, because the patient takes glucose and we take the glucose reading after 1 to 2 hours. So here we can see how the insulin worked and if it did work properly or not. For the fasting, less than 99 is normal. Between 100 to 125, it's considered pre-diabetes. 126 and above, DM. For the oral glucose tolerance test, up to 144. In some books, here in this picture it says 139 or below, differs these 4 or 5 milligrams per deciliter. Normal, 140 to 199, pre-DM. Above 199 or above 200 is considered DM. For the hemoglobin A1C, normal is up to 5.7. 5.7 to 6.4 pre-DM and 6.5 or above is DM. For the fasting, up to 160 is considered normal. 160 to 200 pre-DM, over 200 DM. For the management of DM, the patient should lose weight and exercise. There should be diet changes, and patients can take medications, either oral hypoglycemic agents or insulin. Here are the insulin types: rapid acting, short acting, and so on. Now, dental management, as we said, early morning appointments, taking the breakfast and medication, bring the medications to the dental clinic to know them, and if emergency, consider hypoglycemia and treat as recommended. Hyperglycemia, if it's high, it would be risky, but not as risky as hypoglycemic. Hypoglycemic is more risky. So we treat it as hypoglycemic. Once we find out it's not hypoglycemic, we can fix our procedure. Okay? Now, there's something called diabetic ketoacidosis, DKA. Now, DKA happens in insulin-dependent diabetics. Inadequate insulin, infections, drug use. It has 1% mortality rate. Now, polyuria, polydipsia, dehydration, hypotension, nausea, all of those. Now, the more important thing that we need to know here is that the management is fluids, intravenous hydration with normal saline, intravenous regular insulin as bolus, and potassium replacement and bicarb replacement. Now, pituitary gland disorders. Pituitary gland has 2 lobes, anterior lobe and posterior lobe. The anterior lobe secretes most of the important hormones: the growth hormone, the luteinizing hormone, the follicular stimulating hormone, the thyroid stimulating hormone, and prolactin. For the posterior lobe, it secretes the antidiuretic hormone and oxytocin. Now, it's the workhorse. It's the one that sends all these hormones to the specific glands to cause them to activate, to cause them to secrete their secretions. We talked in the first part about the negative feedback inhibition, the positive feedback inhibition. Now, so the hypothalamus to the pituitary gland to any other glands. Diabetes insipidus is basically a disease caused by posterior pituitary hypofunction. Anterior pituitary gland hypofunction, patients would be at risk of adrenal crisis or hypopituitary coma. Gigantism or acromegaly, it's mostly pituitary gland, anterior pituitary gland overproduction of the growth hormone, hyperproduction. So how can we differ between gigantism and acromegaly? Gigantism before the closure of the shafts in the bones, the growth parts in the bone. Acromegaly after the closure of these plates, the growth plates. Now we can find spacing between the teeth, mandibular enlargement, and local anesthesia is the most suitable means of pain control. Now, the adrenal gland has medulla and cortex. The medulla secretes the adrenaline and noradrenaline. The cortex, corticosteroids. So that's how we remember it. Cortex, corticosteroids. Hypothalamus stimulates the anterior pituitary gland, in turn activating the adrenal cortex. We can, if it's hyperfunctional, we can have Cushing disease, hyperaldosteronism, or congenital adrenal hyperplasia. Now, Cushing disease can be syndrome or disease. Syndrome, it's a primary adrenal disease. The syndrome, basically the problems in the adrenal gland itself. In the disease, no, the problem is in the other glands, in the pituitary basoadenomas, excessive ACTH production by the pituitary gland, all of that. So the adrenal hyperplasia is secondary to these problems. Patients would be hypertensive, would be DM, moon face, mood changes, weight gain, and so on. Now, the diagnosis is confirmed by raised plasma cortisol level and the absence of diurnal variation. Now, cortisol has two peaks during the day. We will find them absent. Local analgesia is preferred for pain control. GA, they will need a lot of corticosteroids and they will not be awake easily. Now, the adrenocortical function may be suppressed if the patient took corticosteroids, either currently on them at doses above 5 milligrams prednisolone, meaning some books say actually up to 7.5. But we can find them in some books at 5, some books 7.5. Most patients will not take one pill. Most patients will take either 2 pills in the morning, 2 pills in the evening, or 1 pill in the morning, 1 pill in the evening, and each pill is 5 milligrams. So they have passed the 5 or the 7.5 easily. Patient has been regular on prednisolone over the dose for in the previous 30 days, and patient has taken it for more than a month within the past year. Now, in these cases, we need to give corticosteroids cover. Now, if we're just giving local anesthesia, or we're doing a composite, a simple extraction, whatever it is, no cover required if he did not take steroids within the past 12 months. If he has taken steroids within the past 12 months, we give usual dose and we give hydrocortisone IV 25 to 50 milligrams pre-op. That's if we want going to do an extraction or conservative dentistry. If he's currently on steroids, we double the oral dose in the morning and hydrocortisone 25 to 50 milligrams IV pre-operatively. And post-op, continue on the normal medications, continue how he takes them. If we're going to go for immediate surgery under GA, multiple extractions, if there is no steroid cover for the past 12 months, we consider if large doses were given. We can test the ACTH. If he has taken them within the past 12 months, we give the usual oral dose in the morning, 25 to 50 milligrams IV, and IV pre-operatively, and at 6 hours interval for the last 24 hours IM doses. So we give dexamethasone, for example, 2 milligrams every 6 hours or 1 milligram every 6 hours, depending on the process. If the patient is currently on steroids, we double the oral dose in the morning with the hydrocortisone and then 6 hours intervals of IM injection for 24 hours. Then, after the 24 hours, we continue the normal medication. So we double the oral dose for the end of the day. For maxillofacial surgery or trauma, if he has taken steroids, we usual dose within the past 12 months, usual oral dose in the morning with hydrocortisone 25 to 50 milligrams, and for 72 hours, double the oral dose. For currently taking steroids, we double the oral dose in the morning, 25 to 50 milligrams hydrocortisone pre-op, and 6 hours interval for 72 hours. So for 3 days, yes. Now, the rule of 2 is another guideline to assess the risk of the adrenal suppression. Basically, it's simpler. It says if the person has taken equivalent of 20 milligrams of cortisone or its equivalent 5 milligrams prednisolone for the past 2 weeks within the last 2 years, he may be at risk. We need to give him cover. Now, hypofunction usually would be Addison's disease. These can lead to hypertension, shock, death. Anyway, okay? The most important thing that brown or black pigmentations can be seen over 75% of patients with Addison disease. Patients can have hypertensive collapse, so we need to give preoperative corticosteroids. If the attack happens, IV 100 milligrams corticosteroids is the treatment, the preferred treatment. Now, corticosteroids can be given to suppress inflammation, to suppress graft rejection, or replacement of missing hormone. Now, here's the potencies. The long-acting are dexamethasone and betamethasone. The highest potencies, the smallest amounts, can give us the preferred outcome. For the corticosteroids or the cortisone, the hydrocortisone, 1. The prednisolone, 4. Methylprednisolone, 5. Now the thyroid gland, the hypothalamus, the pituitary, the thyroid axis, as we talked about, T4 has a half-life of 1 week, converted to T3, which has a half-life of 1 day. Goiter is a non-carcinoma, enlargement of the thyroid gland. It can be due to puberty, to pregnancy, to medications, potassium, carbimazole, and Graves' disease, or whatever. Now, thyroid gland can either hypofunction or hyperfunction. So either hypothyroidism or hyperthyroidism. Now, hyperthyroidism, excess T3, meaning excess metabolism, meaning there will be diarrhea, there will be excessive sweating, there will be excessive increased appetite, but weight loss. He loses weight but eats a lot. Heat intolerance, tachycardia, no voice change, no hair loss, and warm, moist skin. The opposite in the hypothyroidism. Patients will have angina, patients will have constipation, patients will have cold intolerance, decreased appetite with weight gain, decreased sweating, hair loss, hoarseness, and so on. Now, hyperthyroidism management, we confirm it by raised levels of T3 and T4. Should we give lidocaine with epinephrine or prilocaine with philipressine? Which one is safer in these patients? Now, which one is safer? Philipressine is not that safe. Epinephrine is not that safe. So, lidocaine with epinephrine can be used, but with very cautious amounts. because these patients have tachycardia and heart failure. They have atrial fibrillation. So, with these and adrenaline, it will raise, but in a controlled amount, it can be controlled. The complications can be controlled. Povidone iodine should be avoided. Agranulocytosis can happen in these patients once we have, sorry, sorry, once we have very low count of white blood cells, either neutrophils, monocytes, whatever it is, but mainly the most common is leukopenia of neutrophils. Now, it's very dangerous and patients would be at risk of infections. If it's controlled, we can do a procedure. If it's uncontrolled, delay your procedure. Now, the hypothyroid patient, controlled, we can do the procedure. Uncontrolled, we cannot do the procedure. Povidone iodine here is preferred. Why? Because it will be absorbed by the thyroid gland and it will raise the T3. It will activate the thyroid gland to secrete more T3. So it can be helpful. And myxedema coma risk can happen in these patients, so we need to be careful. And that's the last part. Sorry for the technical error that happened. Hopefully, this has been cleared, so thank you.